Now that we've finished with Group A strep, let's now move to Group B strep. So we have Streptococcus AGALACTIAE. That's what Group B strep is. And Group B strep is encapsulated. Important feature you want to know. That's how it can evade phagocytosis, by having this capsule. So the most important feature of Group B strep, and the thing that will be most likely tested, is that it's the most common cause of neonatal sepsis. Most common cause. Whenever you see most common cause, you automatically know that this is very high yield. Number 2 is E. coli. Number 3 is Listeria monocytogenes. Number 1, Group B strep. So the reason why it's able to cause neonatal sepsis, remember neonatal means just born, is that it colonizes the vagina and the perineum. And by colonizing these areas, the neonate can be exposed to these areas during the birthing process. So colonization occurs during pregnancy and is also associated with preterm delivery. So you can get colonization of the vagina and perineum during pregnancy before the delivery actually happens. And if the mother is colonized with Group B strep during the pregnancy, the early stages, the baby can be delivered preterm. So even colonization early on in pregnancy can be pretty dangerous. And that's why you do a screening urinalysis and culture on the first prenatal visit, because you want to make sure there's no Group B strep or any other infection going on, which can cause further problems both to the mother and to the baby. So you preemptively test with a screening UA and culture and treat for any underlying infection. Remember, only in pregnancy do you treat asymptomatic bacteriuria with antibiotics. So the early onset infection, you get that with neonates less than a week old. What kind of symptoms do you get, and what kind of diseases do you get? Bacteremia means GBS is found inside of the blood, pneumonia, and meningitis. Meningitis being the most severe. So for diagnosing the meningitis, you can do a CSF, lumbar spinal tap, and also a culture. And we've talked about all of this in the strep pneumo meningitis slides. We won't go into it again, how you diagnose it and what the features are, but the CSF will be the place where you culture to look for the meningitis. The problem with these bacteremia, pneumonia, and meningitis is they can lead to many severe complications. Especially the meningitis can lead to severe neurologic problems, such as blindness because the optic nerve is damaged, deafness because cranial nerve 8 is damaged, and even mental retardation due to damage to the meninges and the central nervous system. So now the late onset infection is infants older than a week. And this is only causing meningitis. More commonly you get the early onset infection, but you can also get the late onset infection. And this will also cause a meningitis and has similar issues as the early onset infection. Also, Group B strep can cause maternal problems as well. It can cause postpartum endometritis, means infection of the endometrial decidua, UTI, and even infection of the membranes that the baby and the mother are, the membranes that surround the baby inside of the uterus. So the choreo represents the placenta, and amnionitis represents the sac that the baby is sitting in full of the amniotic fluid. So it can affect those membranes that are surrounding the baby and are inside of the uterus. So another thing to know is that strep AGALACTIAE is susceptible to penicillin. But the key feature when we're talking about empiric antibiotic therapy is E. coli and Listeria are not commonly. So you need to treat for this E. coli especially, and also Listeria with some strong antibiotics. And we'll talk about what those are. Empiric therapy is directed towards all possible causes, 1, 2, and 3. We know that there are more causes than just strep AGALACTIAE, and with the severe conditions such as meningitis, pneumonia, or bacteremia, we don't want to just treat for one cause. We want to treat for all the causes. So what are we going to do? We're going to treat with ampicillin and gentamicin most commonly, and we'll talk about that later. What are some indications for intrapartum prophylaxis? So for Group B strep, between 35 and 37 weeks, you culture the pregnant mother's rectovaginal area, and look for Group B strep growing in culture. So you need to see in what situations are you going to give prophylaxis during the actual labor and delivery for Group B streptococcus. So an indication for giving prophylaxis no matter what during labor and delivery is previously giving birth to a baby with invasive Group B strep disease. So that's a very key feature. If they have Group B strep invasive disease in a neonate in the past, all future babies and all future births need intrapartum prophylaxis. Another thing is if you have an intrapartum temperature of at least 38 degrees Celsius. That's another reason to give intrapartum prophylaxis, because there could be a Group B strep infection. And also, more than 18 hours between rupture of membranes and labor. So if membranes rupture a long time earlier and labor happens much later, labor meaning contractions and cervical dilation, then that means there's a long period of time where Group B strep could have infected. So that's another indication for prophylaxis. The final one is a positive screening between 35 and 37 weeks. Remember I mentioned that all women get screened between 35 and 37 weeks for group B strep to prevent these symptoms and these diseases from happening. So if there's a positive screen, that's another reason for prophylaxis. So it's a genital swab and culture or a rectal swab. So if any of these indications are met, you have to give intrapartum IV penicillin G or ampicillin during labor and delivery. So now let's talk about some specific diseases caused by Strep AGALACTIAE. Neonatal sepsis. So this is a systemic infection, meaning it goes through the entire blood system and can infect any organ, and this is due to bacteremia in an infant less than 28 days old. A neonate is an infant less than 28 days old, and they have bacteremia in the body, which is very severe. So it's a major source of neonatal death and disease. And remember, we've got the early onset and the late onset that we described in our last slide. So the reason why this happens is commonly caused by vertical transmission. What does vertical transmission mean? It means from up to down. So remember, the baby is inside of the mother, and the transmission is going from the mom to the fetus up, down. So that's why it's called a vertical transmission. It's transferred to the infant through the birth canal during vaginal delivery. What's a horizontal transmission? Horizontal transmission is basically where I cough in your face and you get the infection horizontally. It happens face to face. Vertical means you have different levels, the mom being taller and bigger, and the baby being smaller and getting it through the vaginal canal in a vertical fashion. So intrapartum prophylaxis, the 35 to 37 week screening, and also the criteria for screening we talked about before, this has greatly decreased the amount of neonatal sepsis that we see, and this is very helpful because it keeps the babies alive. So we like alive babies. Signs and symptoms of neonatal sepsis. Temperature abnormalities. Remember, babies do not have a fully functional and fully mature hypothalamus, so their temperature may be unstable. So they can actually get hypothermia with infection instead of just fever like us adults. Lethargy and poor feeding due to neurologic symptoms. The bacteria can seed the brain and cause meningitis. You also can get respiratory distress, and some signs of respiratory distress, such as from pneumonia or from edema and cytokine release inside the lungs, is tachypnea, increased breathing, grunting to try and suck in air, nasal flaring to try and bring in air also, and accessory muscle use because of the difficulty breathing and the body trying very hard to bring in oxygen into the body through inspiration. You can also get hemodynamic instability, so hypertension and tachycardia because of the bacteria in the blood, stimulating an immune response and cytokine release. So how are you going to manage these patients? So you need to do a pan culture. You don't know what the cause of this sepsis bacteremia is, so you need to do a CSF culture, urinary culture, and blood culture to rule out all the possible causes, and also a chest x-ray to look for pneumonia. So you need pan cultures and chest x-ray. And empiric antibiotics, of course. What are we going to use? IV ampicillin plus IV gentamicin or cefotaxime. So why are we giving these antibiotics? Ampicillin because it's good against listeria and against Streptococcus AGALACTIAE, and also because gentamicin and cefotaxime are good against gram-negatives like E. coli. That's why I use these in combination. These are synergistic with each other. These will tackle the gram-positives. These will tackle the gram-negatives. Now let's talk about postpartum endometritis. So this is a maternal condition that happens as a result of Streptococcus AGALACTIAE. So this is an infection of the maternal decidua. The decidua is the specialized endometrium that's secretory and helps with the baby's development during pregnancy. And it's also where the placenta is attached as well. The reason you get it is because of an ascending bacterial colonization of uterus. So when the cervix is open, remember this is postpartum, bacteria can enter into the closed off area of the uterus, which is usually not open to the outside air. So these bacteria can invade the uterus and cause infection. And usually it's very polymicrobial. You get anaerobes and aerobes, and that'll play a role in how we treat it. What are some symptoms of postpartum endometritis? Remember, this is postpartum, so you'll have a fever, tachycardia, and uterine tenderness due to infection after birth is over. You can also get purulent lochia. What is lochia? So purulent lochia means that the discharge coming from the uterus and from the vagina will be very purulent, yellow, and full of pus. So this is an abnormal type of lochia. What is normal lochia and what does it look like? So normal lochia, the first type of lochia, is called lochia rubra, R-U-B-R-A. Remember, all this is found in the notes at the bottom, so we're just going to talk about this now, and you can look at that later. Lochia rubra is the initial discharge that happens in all pregnant women after delivery. And this is a reddish color because the decidua is being shed, and that's going to cause a red bloody color in the lochia. And this usually lasts for about 3 to 5 days postpartum. Afterwards, from day 6 to 10, you get something called lochia serosa, and serosa will be thinner lochia and will also have a pinkish color. Then after that lochia is complete, from day 11 to 6 weeks, you get lochia alba, and that will be a whitish yellow to yellow lochia, but it's not purulent. It's just a pale whitish yellow color. The purulent lochia will be very thick, very bright yellow, full of pus and necrotic material. You have increased risk of postpartum uterine bleeding because you have an infection of the endometrium, and that'll be shed, leading to bleeding. And also, it'll be difficult for the uterus to contract after delivery, and that'll cause worsening bleeding as well. How do you diagnose it? You diagnose it clinically, postpartum with these symptoms. And the complications you can get is, say that Staph aureus infects the postpartum uterus. It can lead to a toxic shock syndrome due to production of the toxin. Also, you can even get a necrotizing fasciitis or myometritis that's necrotizing as a result of group A strep. Remember, group A strep is a muscle-killing bacteria, and if it seeds into the endometrium, through the endometrium into the myometrium, it can cause major issues. So if you have a rapid progression of disease with high fever, suspect a necrotizing fasciitis. Now, how are we going to treat this? Immediate IV antibiotics. Remember, this is a pretty severe condition. A usually restricted area is being infected and can cause major problems, and it's polymicrobial. So you need to give immediate antibiotics, and we're going to give clindamycin and gentamicin. Why are we giving this combination this time? The reason why is that we have anaerobes, the polymicrobial infection. Clindamycin will cover the anaerobes and the gram-positives, while gentamicin will cover any possible gram-negatives. Metronidazole, why don't we use this? The reason why metronidazole is not used postpartum is because it has very high concentrations in the breast milk, so we don't want to give it if we don't have to. There hasn't been really studies showing that it causes major effects. We still don't want to give antibiotics to a baby too early if it's not necessary. So avoid metronidazole in breastfeeding mothers. So another disease that's associated with Streptococcus agalactiae is called chorioamnionitis. Remember, chorio stands for the placenta membrane, and amnio stands for the amniotic membrane that surrounds the fetus and the baby. So this is a polymicrobial infection with anaerobes and aerobes, just like we talked about with endometritis. So it's an infection of the amniotic fluid, fetal membranes, and the placenta. So the pathogenesis, how does this happen? It's an ascending migration of bacteria through the cervix, just like we talked about for postpartum endometritis, or it can be due to bacteremia. The mom gets an infection, and the bacteria seed into the uterus through the highly vascular placenta. What are some symptoms and signs of this? So we can get a fever, obviously. We can get maternal white count being elevated since we have an infection, so increased maternal white count. And we also can get fetal tachycardia. That's another classic indicator. Remember, the fetus is still inside the mother at this point. So the chorioamnionitis is affecting the fetus and the mother, and the heart will be greater than 160 beats per minute. You can even get uterine tenderness because, remember, all of this is inside of the uterus that's occurring, and even maternal tachycardia. So if you need to remember a couple things, fever, maternal tachycardia, white count, and fetal tachycardia will tell you that the patient has chorioamnionitis. Way to differentiate this from endometritis is that in endometritis, the baby is already delivered, so there will be no fetal tachycardia. You can also get amniotic fluid being purulent and malodorous because of the polymicrobial infection, especially if you have rupture of the membranes. So diagnosis. How are we going to diagnose this? There's a clinical diagnosis with these symptoms that we mentioned over here. And if you're uncertain, you can test the amniotic fluid and look for what the bacterial cause is, if you have a positive gram stain or culture. So things that you can see from this amniotic fluid is decreased glucose. Remember, you get decreased glucose if you have a lot of inflammatory cells or a lot of bacteria. You also have positive gram stain or culture can tell you that there's some kind of chorioamnionitis with a specific bacteria, and also increased white count in the amniotic fluid, more than 30 cells. There shouldn't be white blood cells in the amniotic fluid. There shouldn't be inflammation. So having some white cells is also a major problem and indicator. How are we going to treat this? IV antibiotics, like always. And we're going to treat for the causes. Ampicillin and gentamicin. You can even use clindamycin and gentamicin here too. And this combination will help fight off the chorioamnionitis in the mother. And also vaginal delivery. This is the only definitive cure. You want to deliver the baby because this infection can keep getting worse, and you want to deliver the baby before the baby gets super infected and gets sepsis or bacteremia or even meningitis. So treat immediately and give vaginal delivery to prevent the disease from getting worse. So now let's talk about a sample question. What is the next best step in management? Continue with labor, no urgent interventions necessary. Provide patients with oxytocin to hasten delivery. Perform a C-section on this patient. Provide intrapartum penicillin prophylaxis. Or do a rectovaginal swab and culture. So let's talk about this case here. 34-year-old G3P2, so she's pregnant and has had 2 deliveries in the past, presents to the hospital at 39 weeks gestation in labor, so she's delivering now, and is admitted to the obstetrics ward. She's having regular contractions and cervical dilation to 2 centimeters. She received complete prenatal care and had a negative vaginal and perineal swab for Group B strep. So negative vaginal and perineal swab for Group B strep at week 36, so she got screened. So this is a very good mom. She's getting all her checkups. Very good. However, she does have a history of Group B strep colonization during her last pregnancy, which was treated with intrapartum prophylaxis. She has a history of Group B strep. So we might have to do something here. We'll find out. Now, the patient's currently afebrile and membranes ruptured 4 hours ago. Now, the attending obstetrician is trying to figure out how to proceed. So, we talked about a couple slides ago what the indications are for Group B strep intrapartum prophylaxis. Are any of these met? Let's find out. So continue with labor, no urgent interventions necessary. If none of the criteria are met, then we can go ahead with A. Let's hold on to that. Do we need to give oxytocin? No, it's still very early. She's not in any halting of labor or having decreased contractions. So you don't need to give oxytocin yet. It's way too early to enhance the labor and hasten the delivery. Perform a C-section. You only give a C-section if the baby is in imminent danger or if there's some kind of issue preventing the baby from being delivered in the normal way vaginally. And there's no indication to say that there's going to be a difficulty with delivery here. Give intrapartum penicillin prophylaxis for Group B strep. Remember, we have multiple criteria here. And first of all, the patient does not have a fever. The patient was checked for Group B strep and that was negative. But she does have a history of Group B strep in the past. But remember, the criteria is having a neonate with Group B strep active infection. But this just says that she had Group B strep and that was treated with intrapartum prophylaxis. So that was fine. The baby did not get any Group B strep problems. So that means that D we don't give because we have no evidence of a neonate with invasive Group B strep. And there's no reason to repeat the culture. It will take too long to come back. She's already at 39 weeks, so that'll be wrong. So the answer will be A, continue with management, because even though she has a history of previous colonization, she didn't have an invasive infection in her neonate.